Good evening, and thank you for joining us this evening. Welcome to the League of Women Voters Davis Area October Healthcare Forum. Health Reform and Social Justice, Opportunities for Reducing Inequity and Addressing Health Disparities. An evening with Dr. Susan Rogers, President of the Physicians for National Health Plan. My name is Michelle Famula, and I chair the Davis League of Women Voters Healthcare Committee. And I'm here co-hosting tonight with my colleague, Komal Haq, the chair of our Social Justice Committee. This evening's forum is collaboratively sponsored by the League of Women Voters Davis Area and 44 league chapters across California and across the country, from New York, Pennsylvania, Connecticut, Massachusetts, to Kansas, Missouri, Alabama, Georgia, Florida, Louisiana, Texas, and even Arizona and Washington State. Clearly, healthcare reform and health inequity is an issue of importance to voters across the nation, and we're fortunate to be able to discuss that this evening. Tonight's program has three main goals. First, to stimulate a better understanding of health reform for the general voting public. Second, to raise awareness of the League's nonpartisan approach to legislative issues. And finally, to help create a better understanding of our healthcare system for voters, what is and what isn't working, and how it could be better. Tonight's forum will run for 2 hours, and it begins with a presentation from Dr. Rogers, whose focus on reform will help to further define and explain the impacts of a single-payer approach to reform, an approach our governor in California's Healthy California for All Commission is currently exploring as a unified financing model. We'll follow that with a discussion session in which Dr. Rogers, Komal, and I will further explore some of the areas of health disparity and care inequity. Some of the areas Dr. Rogers defines in her presentation that are present in the US today, and how national health reform legislation might help address their root causes. We'll conclude tonight's forum with your audience questions for Dr. Rogers. If you have not already submitted your questions online, please feel free to enter them in the chat throughout this program, and we'll try to get to as many as possible this evening. This forum is being recorded, and at the conclusion, we'll inform you of how it can be assessed after this evening's forum ends.
Good evening, everyone. My name is Komal Haq, and I'm currently leading the Social Justice Committee for the Davis League. It is my great pleasure to introduce tonight's featured speaker, Dr. Susan Rogers. Dr. Rogers received a medical degree. Ooh, there was a little bit of feedback. Dr. Rogers received her medical degree from the University of Illinois College of Medicine in Chicago and completed her residency in internal medicine at Cook County Hospital. She has spent most of her career at Cook County Hospital, now renamed Stroger Hospital of Cook County, where she was a primary care physician in one of the neighborhood clinics before becoming a hospitalist and director of medical student programs for the Department of Medicine. She has received numerous teaching awards from students and residents. She retired in 2014, but remains a voluntary attending there. She was also previously the medical director of the Near North Health Services Corp, a federally qualified health center in Chicago, and remained on their board for many years after she left her directorship there. She continues as an active faculty at Rush University in Chicago as an assistant professor of medicine. She is a past co-president of Healthcare for All Illinois and is currently president of Physicians for a National Health Program, which is a national organization of over 2,300 physicians and allied health professionals, whose mission is to advocate for single-payer Medicare for all. Dr. Rogers is a fellow of the American College of Physicians and a member of the National Medical Association and the American Public Health Association. Welcome, Dr. Rogers.
Thank you. Thank you so much for that introduction. And just one clarification, Physicians for National Health Program actually has 23,000 members, not just 23. But let me share my slides and can everyone see that?
Not yet.
You don't see them? Wait, let me try and share again. Can you see that? I don't know why this isn't sharing now.
You can see them now.
Okay. You see the slides now?
Yes.
Okay, great. Okay. All right, why don't we get started? And what I want to talk about is single payer. That is what I advocate for. And that is the reform I think that this country needs so that everyone can get access to care and be taken care of medically. Because right now that isn't happening, I think, as we're all aware. When we think about healthcare, the way we access healthcare is through insurance. And when we think, why do we need insurance? Well, we need it because it protects our assets in case we get sick. It improves our access to care because we cannot get care if we cannot show that we can pay. And it is also to protect our health. But unfortunately, the healthcare system we have now with the insurance, the landscape, the fragmentation, the for-profit way it functions, it does not do these things. So it really does not protect us the way we think of insurance, the way insurance should. So let's look at what are we spending now? You know, we talk a lot about how much healthcare costs. We spend a phenomenal amount of money in this country, and this just compares us to other industrialized nations in the world. And here we are at the bottom, and the blue line is what we spend already in public dollars, that is government funds, and that provides the healthcare dollars that pay for the premiums of all government employees, of firemen, of policemen, of Congress, all government employees that paid the premium for me before I retired, since I was a county employee, all our teachers. So when you think about it, this is a lot of people. We're already spending through government dollars more than every other country but Switzerland. So we spend all that money, and yet we have phenomenal out-of-pocket expenses so that we can continue, we can get the care that we need in our current system. And so now we are spending over twice as much as many countries do, 3 times as much as some. And what do we get for all of this? Well, we don't get to live as long. And that's one of the parameters that we look at to see how well countries are doing. We don't get to live as long. We have never had a life expectancy over 80, even before COVID. We've never had a life expectancy that large. And I don't know how we can say that we are the best system in the world with numbers like this. And I like this slide because I think it really puts in perspective how far off we are. All the gray lines on the left side of the graph are countries that essentially have some sort of system where almost everybody is covered in those countries. Most of those countries, they do have a universal healthcare coverage so that everybody has access to healthcare. And not only does everybody have access, they're not spending anywhere near as much as we are. Yet, here we are way out on the right, spending more money and getting worse results. Now, if you were doing something, you were trying to learn a skill or you were trying to make something better, and you knew that you were out way on the far right of this graph, where the United States are, you'd say, I need to change what I'm doing. I need to do something different. There's no way that what I'm doing here is working. And yet we still insist that we have the best healthcare system in the world, that we do everything better, that everything is better here, when obviously we are not. And when we talk about life expectancy, I put this slide in here because when we look at life expectancy, there's different, it's not the same for everyone. And we all know we all don't live as long. My mother-in-law is 92. So, you know, there's people who are way beyond the normal life expectancy. But even within cities, within small areas, and this is just a graph of the red line, which is part of the train of public transportation in Chicago. And if you start down here in Inglewood, which is a poor, concentrated poverty neighborhood, mostly Black, on the south side of Chicago. And if you get on the train and you get off at a stop called Streeterville, which is a wealthy neighborhood, all white almost, that is on the lake, your life expectancy drops by 30 years. So here we have neighborhoods in Chicago with a life expectancy of over 90 and other areas that start at 60. So here, even within the same city, we have stark inequities. And we have to say, what are we doing wrong? Well, it's not just adults that are dying. Our infants are dying. We have the worst infant mortality of any industrialized nation, 2 and 3 times as much as some of them. And when we define infant mortality, that's an infant that dies within a year of being born. And within that number, we have to look at the inequities that are there. And that here we see that that's all of us in the middle. But on the far left, Blacks have the absolute worst infant mortality of all groups. And here are whites over on the right. So there's a large inequity here in just infant mortality. And then even if we look at maternal mortality, look at us compared to other countries. Our mortality is twice as large, 3 times as much as in some. And then there's others that have a minimal mortality. Now, maternal mortality deaths are not a lot. I think it may be 700 or 800 total during the year. But the point is that we are so far above and beyond what other countries do. And yet we still say we have the best in the world. And this is a barometer that other countries, that the WHO uses to reflect on how healthy a country is. And even if we look at white women, they have a higher maternal mortality than other industrialized countries. So the inequity is there in all the groups, all of them, Black women, American Indians, white women, we all have a maternal, and a lot of these parameters that we look at affect others, white people in this country too, because even if you look at the wealthiest of the wealthiest socioeconomic group, white people in this country still die sooner than the wealthiest groups in other industrialized nations in Europe. If you look at the poorest groups here in this country, the poorest groups here die sooner and have worse outcomes than the poorest groups in other countries. So even if we don't look at us all combined, if we compare similar groups in other countries, we are still faring much worse. And then we look at what COVID did, and COVID really sort of visualized and made obvious what some of the inequities are. And what has happened in this country is a lot of these inequities, they're not even aware that they exist. They may have heard about them, but they're not on their radar screen. And when all these inequities came up, the president of the American Medical Association, which used to represent most doctors in this country, they don't anymore. But even she said, we need to do more studies. But the studies have shown why, and I'll get into that in a little bit, as why these inequities here. It has nothing to do with genetics. There's reasons why, and it's reflected in the way our society functions. Now, this is just a picture of an area in Chicago where there is a ironworks plant, and this is a Black neighborhood. And this is where a lot of neighborhoods are, in the middle of environmental pollution, whether it's in the air, whether it's in the water, whether it's in the soil. And yet we tolerate this. Flint, Michigan still does not have clean water. And it's been over 5 or 6 years. A white neighborhood in Chicago, the Chicago area would never tolerate that. But why is that acceptable to the government in the city? Why is that acceptable in minority neighborhoods? And what we have to remember too was when redlining and segregation and Black neighborhoods evolved and grew in urban areas, this is where these plants were placed. This is where these factories were built. They were built around minority neighborhoods. So this wasn't just an occurrence. This was planned to be like this. And so we talk about the social determinants of health, because this is important in how healthy we are. And it's not just related to our access to healthcare or whether or not we have insurance, but we look at our economic stability, where we live, education, our access to food, what the community is, and the healthcare system in that. And one of the things is that the social determinants of health negatively impact more on Black and brown and immigrant communities than they do on white communities. And this is clearly a reflection of the segregation that has been going on in this country since 1900s. But it became legal with the New Deal. I mean, they wouldn't give mortgages to anyone Black trying to buy a home. So they had there were limitations on where they were able to live. So the reason why these social determinants impact minorities and people of color is because of the neighborhoods that they have only been allowed to live in. And those neighborhoods were never supported the way other neighborhoods are. And so what we have now is areas of concentrated poverty. And I like this slide because it shows a couple of things. One, concentrated poverty is where at least 30% of the people who live in that community are below the federal poverty line. Now, remember, the federal poverty line is just a number that determines whether you can get a certain benefit or not. It has nothing to do with whether you are poor or not, because even if you live 200, 300, 400 times the federal poverty line, you are still often poor. So it doesn't determine who is poor or not. It just determines what benefits you can get. But when you live in a community of concentrated poverty, where 30% of the people in that community are below the federal poverty line, you're living in an area that does not have the social supports that you need to be able to flourish. It doesn't have good schools. It is not safe. There's violence. It often does not have grocery stores. It has what we call fast food swamps, because there's often four to five times as many fast food restaurants as there are in other neighborhoods. And so what this shows, so if you look at Chicago, 35% of the people living in an area of concentrated poverty are Black, whereas less than 5% are white. That is because whites can still, no matter how poor they are, can still live in neighborhoods where people are better off, where the economics are better. So white poverty is not the same as Black poverty. And what Black people suffer, and immigrants and other people of color suffer by living in areas of concentrated poverty, is different from white people living in this country who may still be at the same level of poverty, because they live in an environment that is still supportive and that can encourage them to flourish, where we don't have that in this country. 1 in 4 Blacks in this country live in areas of concentrated poverty. 1 in 6 Hispanics, yet just 1 in 13 white Americans live in concentrated poverty. So let's talk a little bit about access. The Congressional Budget Office even projects that by 2029, there'll be 35 million people who do not have insurance. That is, they will not have any access to care. Even when the Affordable Care Act was created, it was never planned to cover everyone. It was never planned to provide insurance to everyone. They even projected that even if the insurance mandate was left intact, there would still be 30 million people who did not have insurance. So even in the best of times, there will still be many people who will not have insurance. And if we look at who was insured by race, well, this is no surprise. The group that is most insured are white people in this country. The groups that are most likely to be uninsured are Blacks, Hispanic, and Native Americans. And the reasons people are insured, the vast majority, is because they cannot afford it. They often have jobs that do not provide it, and those low-wage jobs do not give people the access or the means to buy their own insurance, even on the exchange. They make too much to get subsidized through the ACA. So the coverage is not affordable. There's a variety of other reasons, but that's the majority of reason why people do not have insurance. So let's look a little bit at Medicaid. Now, one of the things that the Affordable Care Act was, it did expand Medicaid. So this was a way that people could access insurance. And Medicaid actually provides health insurance coverage to more people than any other single program. If we look at private health insurance, that may provide more, but there's so many different programs within private health insurance that it can't be looked at as one type of insurance. But Medicaid, it covers low-income children, adults, and seniors, those with disabilities. It covers 1 in 5 people in this country. So 20% of people get their care through Medicaid. Now, Medicaid is federally funded, but state delivered. And one of the things about Medicaid is that people who have disabilities, especially adults, who have significant medical issues and need health care because of their disabilities, but still may be able to work. However, because they have to meet the minimum requirements to receive Medicaid, they are doomed to a life of poverty so that they can maintain the access to the health care they need. So here we are, dooming adults who could be functional and productive in this country. We're dooming them to poverty so that they can access healthcare. Medicaid also covers almost half the births in this country. So that it is a big issue here. It is a big way that a lot of people in this country receive their care. However, it is underfunded and does not even cover the costs of taking care of the people it does. And we are the only industrialized country that has a separate system for poor people. We're the only ones. There are poor people in all of these other industrialized countries that have better graphics, better metrics than we do, but they have access to the same care that everyone else does. Here we make a distinction. We have a separate that is underfunded, and it's a separate and unequal system. They don't even pretend to be separate and equal. It's a separate but unequal system. And here is what happened with Medicaid expansion. Most of the states that did not adopt the expansion were in the South, where actually most of the working age Black men live. And so here they are, and they're excluded from being having access to Medicaid. And keep in mind that when in 1965, with the Civil Rights Act and the Voting Rights Act, and this was when Medicaid became an entity. It was proposed with Johnson along with Medicare, but the Southern states would not allow benefits in their states unless they had control of them. And this is why Medicaid is federally funded but state controlled. And this was because these Southern states did not want to provide access to the Blacks who lived in their areas, in their states. This was on purpose. This was what happened with Medicaid. So it was never created so that all people could have access, because the states are allowed to make their own decisions about what they will cover. There's certain things that Medicaid has to cover, but there's still a lot of flexibility with what states will allow them to do. So this was never meant to solve the inequities that poor people had in accessing care. And the Indian Health Service, I hate that it's still called the Indian Health Service, but this service is still, look at their funding. It's abysmal. The Tribal areas, many of them do not have fresh water. It is still abysmal, the conditions that we allow them to live in and that we support and don't address. So single payer for all would have, everyone would be enrolled automatically. You're enrolled as soon as you're born, you're disenrolled as soon as you die. And it's federally guaranteed. It covers all medically necessary services, and everybody in the country is included and covered. So let's talk about choice. And everybody talks about you need to have a choice. And so they offer all these plans, but it's not the choice of a plan that you want. In fact, you don't even have a choice of a plan because your employer often offers you only one plan, maybe one private insurance and the other is through an HMO. So it's not like you have a lot of choices even through your employer. And what it does is that it limits your choice. What private insurance does, private health insurance, limits your choice of the network of doctors and hospitals. That's the choice you really want. You want to go to the doctor you want to see to, and you want to go to the hospital that you want to go to. You don't want the choice of insurance plan. You want the choice of doctor and hospital. And if you end up going out of network, which may happen, and you don't even know you're out of network, you end up with bills. It's difficult. It's not impossible to really figure out what your plan has. And so even though you and your provider may decide on what you want or what you need, it's still up to the insurance company to approve that. So you don't have choice about anything. Your doctor doesn't even have a choice about, it's almost as if the insurance company is practicing medicine without a license because they are making the decision about whether you need something or whether you can have access to it. So let's talk a little bit about benefits. And what happened when the ACA came out, it did reform insurance and it did mandate that they had essential benefits, which was new. The biggest of which was the coverage of pre-existing conditions. But it did say in these essential benefits that there were certain, in 10 different areas, there had to be benefits in all those areas, such as physical therapy, pediatrics, obstetrics, long-term care. But it didn't set a national standard. So each plan can offer different things and you have no way of knowing. The plan may say, yes, we cover your diabetes, but it may mean you only get 2 strips to check your sugar 2 days out of the month. The rest you would have to pay. And there's no way you would ever know that until you tried to get it and you got refused. It does cover pre-existing conditions, which is a big benefit. And one of the things that it did say was that they have what they call a medical loss ratio, which is 80 cents of every dollar from your premium has to go to provide healthcare. But they play around with that and what they decide healthcare really is. And all they'll do then is as costs go up, they increase your premium so that they can maintain that 20% profit so that their salaries get paid and they're really never going to lose any money. So single payer would cover all the things you need. And by making it coverage for everybody, when you have coverage that is acceptable to wealthier people, then it'll be okay. You know you're getting covered for everything medically necessary. And one of the things that is not covered is nursing home care now through Medicare. We don't cover dental, we don't cover eye, we don't cover hearing. Mental health services are often very abysmal. So that this would expand coverage for everyone. So let's talk a little bit about quality. With single payer, we would have better quality because like I just said, it would foster quality by making what it covers acceptable to everyone. And it could help reduce the inequities that we see because it would improve access. Now, I mentioned the social determinants of health, so I'm not naive thinking that once we increase access, things will be fine. It won't be, but that's a necessary step for you to be healthy is to have access along with the other social determinants of health. The system would provide continuity of care. Right now, the only place where you can go if you don't have insurance is an emergency room. They have to see you. However, you may be diagnosed with something that may not be an emergency and require admission then, but may require further care later, but you won't have access to that further care. And so that's the problem with what we have now. Once you've been discharged from the ER, you really have no way to access follow-up on whatever it is that you went to the emergency room for. So we would provide continuity of care. You would be able to get preventive care. Right now, we don't do much good. We don't do good preventive care at all. Insurance companies don't want to pay it because if you do a screening exam for cancer and they find a cancer, then they have to pay for that. So they don't want to screen and find anything. And so you often have to go through hoops just to get a colonoscopy or to get a mammogram. It would also help to make an electronic medical record that talks to everybody so that if you see a doctor in New York and then get a follow-up with a doctor in California, both those doctors can see your medical record. That's the way the VA functions. I worked at the VA for a couple of years and it made it so much easier because I knew what all had happened with that particular veteran in terms of their health care. And you could provide real health planning by putting resources where they're needed rather than they make money. Right now, we have areas that are medical deserts. Hospitals have closed. We have counties in rural areas that do not have a hospital. So there are a lot of medical deserts that are there because of the funding, the payer mix, they often are not able to survive. So what single payer would do with global budgeting, and I'll get into that in a minute, is that it would build resources and you would have places, hospitals, clinics where they're needed versus where they can make money. Where I am in Chicago with Stroger Hospital, Cook County Hospital, within this mile radius, there's Rush University Hospital, there's the University of Illinois Hospital, there's a large VA hospital. Why do we need all those clumped together? Why shouldn't they spread out? And we have to look at it the same as with a fire department. You would never stop at a stoplight and see a fire station on each corner. That makes no sense. You want the fire stations to be where they be close to where they can put out fires, which means they have to be spread out in a manner where they can, where everybody has equitable availability to the fire department to put out a house. Just like it's just as important if the house next door to you catches on fire, you want it to be put out. Just like the person standing next to you in line is ill, you want them to be healthy so that you don't get sick, especially with COVID. It's, when we have communicable diseases. So let's talk about costs because that's the biggest thing that everyone talks about. Our healthcare costs too much. And this is what we are paying now for employer health insurance. And this bottom line is what the average family premium was for an employer was $20,000. And often your employer pays 2/3 of that, which leaves you never see this money because it never gets into your check. It's deducted from your salary. So you're paying 1/3 of that out of your salary. Well, you're not paying it out of your salary. You're paying 1/3 of it, which could have gone to your salary if we had a single payer program. But this is what is kept by the employer to help pay for that entire premium there. And what has happened along with you paying that, you also have a high deductible. And one of the things that happened when the Affordable Care Act was established is that they focused on the costs of premiums, but they really didn't pay much attention to deductibles. And this is why deductibles have skyrocketed so much. And this is how insurance companies make even more money, is that this is an out-of-pocket expense that you have to pay before your insurance company pays a dime for your care. And keep in mind that this deductible is only pays down when it's covering an expense benefit that is covered. So if you buy a pair of eyeglasses and that's not covered by your insurance, that doesn't bring down your deductible. That's further money that you have to pay out of pocket. And most insurance plans now have high deductible plans. And what this does is it makes it so that people cannot access their insurance because they cannot pay down their plan. If you look at the bronze plan on the exchange, which is the cheapest premium there is, that plan also has the highest deductible. So some of those bronze deductibles are over $12,000 a year. So tell me how somebody who needs help paying their premium is able to pay $12,000 a year so that they can access their insurance. This is how they have played with the system so that they never have to pay for your care until you pay down your deductible. And so it's not fair, but it's legal. And this is how they have played the game. And so what this has done is created a system of what we call underinsurance. Underinsurance is where you have to pay, depending upon your income, you pay 5 or 10% of your income for healthcare. And that makes you uninsured. If you're paying that much money just to keep your insurance going, you're not insured. And this is why people go broke. This is why people end up making GoFundMe posts on Facebook, is because they cannot afford their care. It's like what you have in your wallet isn't an insurance card. You have an insurer donor card because you're paying every month to this insurance company for something you're never going to benefit from. It's just like if I gave you the car of your dreams, but didn't give you the keys. The car is only good for you to post pictures of Facebook with you sitting in it as if it's yours, but you can't use it because you don't have the keys. And if we look at who has financial problems because of medical bills, a lot of people have used up all of their savings. They declare bankruptcy. It's not sustainable, and prices continue to go. And more people are going to have financial problems because of this. So where is all of our money going that we're spending? We're spending these phenomenal amounts of money, but we often can't get the care we need. Well, we spend a phenomenal amount on billing because the way that a hospital, a doctor, they get paid is through administrative costs so that they can get paid. And this is through billing. And it's a coding process. It's complicated. It requires a lot of expertise. It requires a lot of time. And a lot of physicians end up spending 25% of their income just on this administrative cost. Hospitals spend 25% of their income on administration. And this is just a typical large institution. Duke University has more billing clerks than they have hospital beds. Now, I don't know if you've ever been in the hospital or you've been to visit someone or you work in a hospital, you know, sometimes it's difficult to find a nurse, but you can clearly find a billing clerk when you need one. And so this is what has happened, is that administrative costs are just taking all of this money out of healthcare without using our healthcare dollars for something that does not provide health. Also, if we look at what things cost in this country, you can Google any procedure, anything, and you'll see comparisons of what we pay compared to other countries. And this is what we spend. We spend 5, 10 times, 100 times as much as other countries for procedures. This is just for a cardiac bypass. And you can see we are such an outlier here. And then what we spend on drugs. We spend phenomenal amounts of drugs and pharmaceutical companies always say, well, we need all this money because we have to do all this research. But we have paid for that research through our taxes because the NIH has done all that research. The NIH did a lot of the research on the vaccines that we have for COVID. But there was a provision called the Bayh-Dole provision that allows private firms to monetize publicly funded research. And this is how these pharmaceutical companies latch onto these drugs. And when they do their clinical trials, which is actually the cheapest part of research, and then they make all this money and they put it on patents. which means nobody else can make that drug, and patents last for 20 years. And then they may do a little adjustment, so they add more time to the patent. It's a game, but they're not spending all this money on research, which is what they want you to believe. And there was a drug that came out to treat hepatitis C, which was actually, people don't have symptoms, but it can cause cirrhosis and eventually death, and it can increase your risk of liver cancer. And the company who made it, Gilead, actually made a comment about, is curing patients a sustainable business model? So these pharmaceutical companies, their goal and mission is to make money. It is not to provide low-cost, curable drugs to the people who live here. That is not in their mission. And if we had negotiated prices, we would have saved $71 billion over the last 6 years if we had paid the prices that the VA negotiated for. The VA has a system. They have one network for all their VAs across the country. They buy their drugs right from the dispenser. They don't go through pharmacies. They found a way to do it cheap. And now we're even though we have this data, the government, Congress is still talking about negotiating whether we should allow Medicare to negotiate drug prices. So the market has done nothing, and people keep talking, let the market figure this out. It won't. But all it's done is create worsening of the problems that we have now. And everybody is unhappy. Physicians are frustrated. And I think that we should really be concerned because there's more and more physicians who are leaving healthcare because the situation is not sustainable for them. They're frustrated. They can't do what they spent all these years learning how to do, which is take care of patients, because the decisions aren't there anymore. The patients get frustrated because they can't get the care they need. Physicians are frustrated because they can't provide the care that they want to do. They spend more time with administrative costs, doing administrative work. And the market has done nothing to control costs. The government has to control costs, and it's not doing that. Now, single payer offers real tools to contain costs. One is with global budgeting, where a hospital would have a budget, and if a pandemic occurs and they spend more money, then they would get more money from the government to provide that care. If they spend less care, that money goes into the next year's budget. It's not profit. They can't decide to build something or to provide a service that makes more money. And we would invest, it would be capital investment would be separate. So they can't just decide they want to build something with that extra money. It has to be approved. Now, this is tricky because we still have to have a lot of oversight to make sure that minority neighborhoods and other poor neighborhoods are still treated equitably, because we have to make sure this does not go the way public education has gone. Public education is government funded, but clearly it is not equal. And there are schools in poor neighborhoods that are not funded because it's built on property taxes, which itself is inequitable. So we have to have a system that it provides equitable services, and that will require oversight. And this makes economic sense. Everybody says this. There have been studies that showed this. Even the Koch brothers did a study that showed that we would save money. And we have to treat it as a public good, and so it doesn't follow standard market rules. And doctors now support single payer. More and more doctors, mostly Democratic doctors, but still more and more physicians support single payer. Even some such specialists are now, the high paid specialists are now supporting more single payer. And I want to show this because there is a way to do this right. That if we followed what Canada did back in the 70s, we wouldn't be on the trajectory that we are now with our private health insurance plan. If we follow Canada with a single payer plan that was government funded and everybody had the same benefit, we would not be anywhere near we are. And I show this slide again because here we are this far thing on the right, and we refuse to look at the right way to do this. Just like if you refuse to change the way you're doing something, rather than looking at the way it's being done right, and we refuse to do that. So this is why we can't get this fixed. And, you know, as time has gone on, especially after Citizens United, I don't see much difference anymore between Congress and private corporations, because private corporations have bought Congress with all of their lobbying. And this is why the government is not making any solutions or doing anything to change what we have now. So this is just a list of some websites that are phenomenal in terms of the information that you can get from here, statistics, discussions. These are all useful in terms of helping you figure out what is wrong and how we can get it better. And there's now, with further privatization of public health insurance in terms of Medicaid and Medicare, once this becomes totally privatized, that's frightening, and it's happening now. Medicare Advantage is really worse than traditional Medicare. It may be a little cheaper in the beginning, but in the end, it is not going to be cheaper for those who choose it. And it's almost impossible for you to get a supplemental plan if you want to go back to traditional Medicare, because you won't be able to see the provider of your choice because of the narrow networks of Medicare Advantage. But take a look at these websites and see if, you know, you may get some answers to some questions, and they're good to follow. The PNHP website there has a lot of information, a lot of videos on there that you will find useful. So I hope I have convinced everyone here that single payer is the way that we can fix this, because the problems are rooted in our private health insurance.
Thank you, Dr. Rogers. That was a really, I would say, comprehensive presentation. And I think it addressed a lot of implications of disparities. And I just really kind of from here on out want to start off our discussion with a reflection on your thoughts regarding our current healthcare system, but also how we have come to accept these inequities in our delivery system. Like, when did we become not necessarily complacent, but almost complicit in this kind of, in the 1970s, it seemed like from your charts that there was a divergence, and how did we allow this to really happen? And what do you think were kind of like the underlying factors?
Well, you know, if you look at the culture of this country, this sense of a public good has never been embraced by the whole country. We have a sense that you have to earn things. You have to earn access to healthcare. And by earning, I mean you have to pay for it. Mm-hmm. And that if you can't pay for it, don't expect it to be as good as what other people who pay for it get. And that's what has happened. And it's not just with healthcare. It's with, I mentioned education before. And unfortunately, this country does not have this sense that everyone should be entitled to some things. And I think it's rooted in how this country was built. This country was never built to be equitable, ever. And if you look past at the last, 150 years since the end of the Civil War, it has maintained all of these structures to continue these inequities. And because also this country is so segregated, purposely, people can live by not seeing things they don't want to see. Mm-hmm. I've had, I remember a friend a person I worked with was complaining about the ride to her house from the airport. She had to see neighborhoods she didn't want to see. So it's easier to just pretend they don't exist, or if they do exist, it's their fault. Mm-hmm. Yeah.
I think that's why it's so important for kind of public education a lot of people don't even realize they are playing a part in the systemic racism. In the last year or so, you know, a lot more people have been, well, the people who want to educate themselves have been educating themselves. And so I think that kind of public education is really, really important. And that isn't just for healthcare, like you said, even like our school systems.
Mhm.
But how do we now help enact this change? I mean, yes, it has to come from a social background to actually act upon it, I think. But how can we make the public kind of trust our healthcare system and these policies and kind of work towards building a better future and a more equitable future? And this is for Michelle or Dr. Rogers, you, whomever wants to chime in. Michelle, you're on mute right now. Just wanted to let you know.
Yeah, I think that, you know, there's been quite an issue around trust in our healthcare establishment. And I think what you find now, and some of it has to do with how we are financing health systems and how we've removed really agency from both patients and providers. And what we found and what we're continuing to find in COVID is tremendous distrust of what were considered to be sort of the hallmark agencies. You mentioned the NIH and the CDC and the FDA. And I've really been concerned about this erosion of trust, really in all of our government institutions, but in healthcare, you know, we say that people trust their own doctor. If you want to encourage people to get the vaccine, put it through their own doctor, not through clinics. And yet, so many people can't name their own doctor, or the doctor they had 3 years ago isn't their own doctor anymore because their employer changed insurance coverage. So I see this as a big part of trust. And I'm curious, Dr. Rogers, how you see the system and how it plays into how people are or are not trusting the healthcare system now.
Yeah, the trust part has been decimated. And, you know, even when we say, ask your doctor, you know, the health inequities in this country, the large percentage doesn't have a doctor, has never had a doctor. They may just go to the emergency room, or they end up going to the hospital, you know, because things got so out of hand. So there isn't access to even have that relationship. But I think that it's hard to describe what has happened in this country, you know, as to why the FDA isn't trusted, why healthcare isn't trusted, you know. And there was you know, it's sort of, I saw a tweet that someone, a physician wrote, and they said, you know, the patient complained when I asked her about getting a vaccine, she didn't know what was in it. And she said, the doctor responded, you didn't ask me what was in the 4 medicines I just wrote you for the prescription for. So people are choosing what they want to believe. I don't think it has anything to do with trust. You just choose not to believe what that group says. Because I think in general, patients who have relationships with their doctors believe their doctors, or they would have changed if they could. But that relationship has been eroded by the insurance companies because you can't always follow your own doctor.
Mm-hmm.
My daughter, who, when she was pregnant with her first child, had to switch OBs because of the insurance change. And that was beyond, and she didn't want to do that. And then the hospital where the other OB was, you know, 40 minutes from her house. I mean, so this whole system is not made to work on trust. It's made to make money.
Mm-hmm.
And I don't care if you can't go to the doctor you like, you're going to Dr. B, who was just as good as Dr. A, and, you know, and that'll work. And that's how, because now physicians are looked at as employees now. They're treated as employees. You know, I know that I was in primary care for about 14 years before I became a specialist, and I worked in a county neighborhood clinic. And I saw those patients over and over and over again. And that's why I love primary care. And I'm sad that so many medical students who are looking forward to that kind of experience won't be able to see that. They could if we got a single payer system. But the system, the economics of healthcare have made it difficult to build those relationships. And trust comes from relationships.
Mhm.
And if the health system actively destroys those relationships because it's not in their economic interest, it's creating the problem. And, you know, it's part of the whole disruption of, I'm trying to find the right word, but it's just disrupted what was there. What used to be normal has been disrupted, not just in healthcare, everything has been disrupted here, you know?
Okay.
It's really changed the architecture
Yeah.
of the entire system.
Yeah. It's just, and I'm not sure how we can, you know, build it back. I mean, if you look at hospitals that, you know, Hospital A is a great hospital. They care about you and all this. And yet during the pandemic, they made billions of dollars,
Mhm.
you know, while people went without care.
I wanted to share a story as well. One of my friends, I think it was 2 weeks before she was due, her hospital dropped her as a patient. She had had this continuity of care with her OB and the whole team. And I think up to a week before she was due, she was sobbing. She's sobbing on the phone with her insurance company. And that caused her a lot of trauma to a point where, you know, giving birth again and going through that process is now, it's a triggering effect.
Mhm.
And this is just one instance. I know plenty of people and they live in 2-income households. It's the fact that she couldn't stay with her provider and then had to go through this kind of trauma right before will decrease. Right now, there's a lot of talk about, you know, birth rates are going down for my generation and younger generations. But I think we have to realize the cause and effect that the healthcare delivery system and private insurance companies are having on these kind of quote unquote, like millennials are just being selfish. These terms that then come upon, like, you know, African Americans are just lazy. No, there are historical contexts that have led up to this point and led up to their circumstantial needs that are not being met. I think some good things that are coming out, someone had commented in our chat, was Henrietta Lacks cells that, you know, the family is now filing a lawsuit on.
Mhm.
We didn't even know that information, that these things were happening, you know, in the past, all of the medical experimentation that was going on without consent. And even currently in ICE shelters, I think it was either last year where it came out that there was sterilization happening without consent. I think the more knowledge of this that is being presented to the public, I think bringing that awareness will help, and understanding that awareness will help providers and community partners deliver that care. Maybe we do make things a little smaller. You know, we enact these mistrusts with community partners, people who speak the language, who understand culturally competent care, people who are representing the population they serve, having mobile units go out. It will take a lot more workforce, and I think it will take a lot more effort and funding, but I think maybe this is the kind of, I guess, policy work that the public and voters can kind of get behind, but we also need champions of change to kind of put forward this policy. What are your thoughts on this kind of work? Do you think it's possible to have healthcare policies with this kind of radical change happen in the next couple of years?
Well, you know, as long as we have a profit-driven healthcare system, the relationships will always be transactional.
Yeah.
They're not going to be personal. You know, it's like, I don't really care how nice the cashier is at the grocery store, just don't break the eggs I'm buying, you know?
Mhm.
It's impersonal, but with healthcare, it has to be personal.
Mhm.
You know, you're often talking about things that are very personal that may have significant impacts on, but even from the source, if you look at how insurance companies try to, you know, downplay that, and they talk about the choice you want is of the health plan, not the doctor, not the,
Yeah.
but the plan, that's what's important, you know, forget the person who's treating you. And so everything has become, and I think that the obvious defects in this loss and disruption are so obvious with healthcare because it's something that we all get impacted by. Even if it's not personal, it's by somebody that we know in our family, who we work with. We all see it, even if we don't personally, live it, you know, but it comes from the top. And there's a man, Wendell Potter. I don't know if you've heard about him, but he's very active with PNHP, and he also has a blog that he has, but he was a big VP with Cigna Health Insurance. And there came a case, and this was on the news, about a young woman who was in her early 20s. I don't know what her medical issue was, but she needed a liver transplant. And Cigna said, no, it's not necessary, or it's not time, she's not ready, we need to wait. And so there was a big uproar, you know, and all that. And people protested the whole thing. And finally, there was such a media thing that Cigna backtracked and they said, okay. But then the next day or 2 days later, she died. So their decision was made too late. And that's what caused him to leave. He kind of knew this stuff was going on, but this was his tipping point. And now he's a fervent single payer supporter. He is so anti-health insurance company because he looks back and he's embarrassed by some of the things he did, because he was very good at writing up and delivering the lies that insurance companies had created, so that, you know, and the thing is that they are so far away from the problems.
Mhm.
Because they're, you know, and, you know, if we look at how this is impacted, look at like the Cleveland Clinic, massive institution, you know, it's almost like a city in itself in Cleveland, Ohio. People come from around the world with cash in their pocket to pay for whatever their health care is that they need. Yet the community across the street has the worst health outcomes of the entire state of Ohio, because they are not welcome in the Cleveland Clinic.
Are there drivers of funding though? Like, you know, I don't know too much, but you would think if your community is healthy, you would get maybe some grants or funding to kind of keep your checks and balance, to keep some kind of accountability.
Even if those, but you shouldn't need grants. If you have Medicaid, you should be, but the CEO there said they would prioritize patients for care, and Medicaid would go to the bottom because their reimbursement was the least.
Yeah.
And it shouldn't be that if I take your gallbladder out or I treat your hypertension, that I should get more for each service depending upon what you can pay me. It should cost the same, you know, for each thing. But it's that culture that sends the message that it's okay to be like that.
Mhm. Yeah.
And the fact that we tolerate it,
Mhm.
And I know, friends, and we make jokes. I don't know what's wrong with me. Well, you should go to Mayo Clinic,
Mhm.
they'll figure it.
WebMD has become many people's diagnosing physician. It's hard. It's hard. You don't want to pay for the cost. Sometimes even with decent insurance, that $20 copay over time becomes too much of a financial burden.
And I know we talk a lot about what is affordable health care. Well,
Mhm.
that's such a relative term.
Exactly.
What's affordable to me may not be affordable to you, and it's certainly not affordable to somebody who's homeless.
Mhm.
But what is affordable health care?
Mhm.
It should be free at the point of care. Then it's affordable to everybody. And there's no way around that. There is absolutely no way around that. And working at Cook County Hospital, having seen so many homeless patients, and it's difficult to decisions on to
Mhm.
discharge them, knowing they're homeless in the middle of winter.
Mhm.
I'd like to take us back to one of the things you alluded to before and that we've talked about. That's come up several times in the chat as well, is this idea of having access to primary care providers and a little more broadly, just having access to the right workforce. We know that there are shortages in nursing. We know that there are shortages in primary care providers. I'm curious what you think has kind of led to this imbalance in the system about sort of the match with workforce with what the country really needs, and how health reform might be able to address that in an effective way.
What has happened is that subspecialists make so much money. And what is driving a lot of people to go into that are medical school loans and student loans. And that, if, after college and medical school, you may owe several $100,000s in debt. And let me tell you, what I got paid as a PCP, I'd still be paying off that loan, and I still wouldn't have been able to buy a house, and I still wouldn't, have a nice car. But that's what feeds into hospitals.
Mhm.
And so the whole system it revolves around making money. And those doctors that make the most money are the ones that are most supported by the hospital. And insurance companies will also, they don't pay PCPs, they don't pay, primary care doctors, pediatricians, the family practitioners. And because, we're just thinking, we're not performing procedures, but it's sort of like, but I'm not quite sure why we don't generate any money for the hospital. Because I see a patient, sometimes they have to be admitted, but most of my patients go home when they leave me. However, the specialists and the surgeons and all of that, they're doing procedures and they're generating money. And so they're not going to complain about their salaries. And so that's part of the medical industrial complex.
So I'm wondering, in reform, how does that fit into reform from your vision of it? If we are looking at any type of single payer or I want to say government funded, but it's not really government funded. We're paying into all of this right now, and yet we have a system like this right now, despite all the number of people that come through Medicare or Medicaid or even the VA system. How does that change from your perspective in a single payer or really any kind of health reform, public option, anything? How would that be able to be changed, do you think?
Well, if we got rid of the for-profit system, there wouldn't be this medical industrial complex, because it wouldn't be driven by money. It would be driven by taking care of people and doing what we're supposed to do because this is what we want to do. And there's nothing wrong with doing procedures and doing surgeries. Those things are needed, but you shouldn't take out an extra gallbladder that doesn't need to come out just because you want the money, So a single payer system would help because there is more need out there, and the people who are getting unneeded care will likely get less of that, and the people who need care will get more of that. But one of the things we support is paying primary care physicians more, paying pediatricians more, paying family practice doctors more, paying, so because one of the things too, physicians who take care of Medicaid patients don't get reimbursed to cover their costs. Hospitals don't get reimbursed to cover their costs. Those are the hospitals that are closing. Our hospitals whose payer mix is Medicaid and Medicare because they don't reimburse enough. And interestingly, and I know the Congress has to know this, but because of all the lobbying money, because when they decided, to give money back to hospitals who were losing money through COVID, how they decided how much to pay them was based on how much money they earned the year before. Well, of course, a hospital who had Medicare, Medicaid patients brought in less income because their payer mix did not pay as much. So who got the most money? The hospitals with the most private insured patients who were sitting on billions of dollars in endowment, who were not in any financial distress, whereas the other hospitals got less money. So so here, this is a policy that continues this structure without even, I don't know if they thought about it or they just were going with the money and, I get money from pharma, so I have to vote this way, but it's part of the structure, the structural racism that, prevented money from going to poor hospitals and poor communities. It's just these policies get made without looking at the whole picture. You just look at, and that's even with algorithms. There's been a lot of talk in medical care about using algorithms to decide what you should do and shouldn't do. And in one of these algorithms, they looked at patients who spent the most money on healthcare. They used that as a surrogate, meaning they were sicker. But what it didn't think about was that I'm too poor to spend much money on healthcare, but I'm actually sicker. So that algorithm disenfranchises poor, sick patients. So we have a structure that doesn't see the whole picture in every aspect because it chooses not to. Those are active choices by policymakers. Those are active choices. And
so when we have patients that are identified by the payer that they come in with to the healthcare system, we know we're going to get differential reimbursements. I am presuming that if we all have the same payer, then it really doesn't matter where the patient took the bus from to come to our clinic. We're going to get reimbursed as clinicians based on the care that we provide, not based on whether or not this governor in this state has decided to reimburse at this rate for this impoverished population versus what the insurance has to negotiate in order to be able to get contracts with the hospital.
Exactly. And this hospital doesn't have to make more money to build a new cancer treatment center so they can make even more money. I mean, that motive will be gone because they can't build that cancer center. They have to get approved for that. And the hospital doesn't need the money that it used to have. It doesn't need that office full of billers, a whole nother wing full of billers, because they won't need that anymore. So it would make a much more efficient system, and everybody would get the same care. And we'd have to, again, stay on top of it, because we all know that there are ways to work around things that should be dispersed and distributed equally, but they're not. I mean, you know, we talk about the algorithms, even with getting mortgage loans, even though, you know, they're approved, you can't be denied just because you want to buy in a Black neighborhood. There's still ways to deny people. And so there has to be oversight and some acknowledgement that this is the right thing to do. Because, you know, it's like, you know, teenagers, you know, well, I'm only doing it because you said I had to, even though you know it's the right thing for them to do. Eventually they'll learn, but it has to be part of the culture that that's the right thing to do. And I worry that we're very far from that. But we have to start. We have to start.
I also wanted to mention, I think if people could get paid, like if primary and clinics and hospitals could get paid in this way, there would be a lot better integrated, holistic care. I didn't know till maybe a few months ago that a lot of federally qualified health centers don't get paid for mental health visits if it's on the same day. I thought that was ridiculous. I think that is such a loss for the general public, for the community health aspect of it. It would be great if a patient comes in, they've already taken care of childcare, right? There are so many different factors. Transportation, say they made it to the clinic. Now, of course, you want to serve the whole patient. But because of funding needs and financial restrictions, you are unable to, they would have to come in on a separate day, take more childcare, take more time out, call off work. There are so many factors that would make them be more at a financial loss, just increasing the disparity gap. I could not believe what I learned. And removing that factor would just make society just better holistically. And we could maybe focus more on preventative health and treating the patient as a whole. I don't, you know, it's kind of bewildering how these systems have even come to be.
They're made because that there's this sense that people are just trying to get more, you know, and that they don't deserve it. It's free, so they want it, you know, and it's that part of the culture too, especially against poor people, you know, is that they don't want, you know, they just want what's getting, so whatever I can get today, I want it all, you know. It's that it's out of ignorance that these things are there, these policies are made, because they don't choose to learn about the community that they're delivering care to. And I mean, even when I went to Cook County as an intern, I mean, I was, you know, 24 years old. I had spent a lot of time in school. And I mean, I had to learn some things, you know, and, you know, acknowledge that, you know, everybody didn't grow up the way that I did necessarily. You know, not that I was wealthy and, you know, whatever, but so but there has to be some acknowledgement that there is a world different from the sphere that you live in, you know, and it's not all, and clearly these inequities show it is not homogeneous. This country is not homogeneous. And one of the things that's going to happen is because prices are going up so much and there's more and more people who cannot afford healthcare, that the system is going to collapse. I mean, it's not sustainable. And I like an example that I remember. I don't know how this popped in my mind, but it's one thing I remember from medical school and parasitology is that a good parasite never kills its host. And these insurance companies are parasites, and they're killing us. And they're going to keep killing more and more. It's not sustainable.
And we need to be the antibiotic.
That's a good one. Yes. Yeah.
I
in there.
want to just talk a little bit about care quality, because I think when we talk about changing how healthcare is financed or how it's delivered, a lot of people are concerned, but I won't be able to get as high quality care as I can get right now. And other people who have recently experienced the healthcare system, and you talked about delays in terms of authorizations, which I think is a very common thing that people experience, anywhere from just getting an MRI of their knee to being approved for hospitalization. I'm curious if you could comment a little bit about quality of care and how you would see health reform impacting quality of care. You talked about life expectancy, and we are no shining star there. Clearly, infant mortality is a disgrace for this nation, as is how apparently we treat pregnancy, when 50% of that is on a government assistance, because we don't have the kind of available health care for women that they really need to have healthy pregnancies. And then I'm going to go on a little long here. I apologize. Just recently in your own state, they got permission from Javier Becerra to go ahead and continue Medicare coverage as a pilot to go through the first year after delivery, and not just the first 60 days. And as anyone who's ever been pregnant knows, if you're going to have a healthcare problem and it doesn't occur in the first 60 days, that doesn't mean that you're going to have a healthy infant for that whole year while you try to figure out how to take care of the mother. So quality is a real issue, and I'm interested in knowing how you think health reform can address that.
Well, health reform can address that in several ways. One, it would allow for continuity of care so that you don't get half treated for something, because you can follow up and you can get what's needed and you can get all the care that you need. I think that there has to be, making the care equitable has to be. You can't have hospitals prioritize which patients they want to, take care of. And that's what's done in this country is, people criticize Canada and saying that people have to wait for so long for care. And that's why our system is so better. But people don't realize that people are waiting forever sometimes. I'd rather wait 3 months rather than forever for something that I needed. And I think that depending upon your frame of reference, what is quality will differ. But that's why we have medical guidelines. This is how you treat certain things. You need this antibiotic, you're doing the right things. And as a non-healthcare worker, you don't understand that aspect of the quality because you don't know how to treat things. That's why you come. But I think quality will improve by making it equitable, and that everybody gets the same. And then that you're following a standard of care. Now, there may be people who think that I'm getting better care at this hospital because I have a view, and emotionally you will probably feel better with that view, but it's not, so there's things that people will expect because it's sort of like, what's a nice car? It varies. Now, if you've only driven a real high-end car all the time, the bottom line of a Ford may not be acceptable to you, but we have to make sure that services in all areas are equitable. So that people, if you have hospitals that are bare bones and, uncomfortable, people won't go there, especially if they have a choice of going anywhere. So, but quality is, a hard one to figure. But one of the things though, is that if with a single payer system, there will be, especially with public hospitals that are affiliated with medical schools and academic centers, that will grow, that will flourish. Right now, we have hospitals that, if you look at, I look at Cook County, that is struggling, even now, but it's affiliated with medical schools. It's an academic center. There's research going on there. I mean, and when you're affiliated with a medical school, you have to have a certain level of what you're providing. Okay, I had to do certain things to be able to get on the faculty of Rush, so that all hospitals, if they're affiliated with this, and they can be, that quality would become more equitable. Now, everything is never going to be exactly the same, but if we have a single payer system, it shouldn't be that in a poorer community, your hospital is so substandard. Because right now, there's some hospitals that get radiology equipment that is phenomenally expensive as hand-me-downs from other larger hospitals that are upgrading theirs. And it doesn't mean that that machine won't work, but you're creating two tiers here. Mm-hmm. And that's what we're doing now. We're creating different tiers of care, depending upon how it gets paid. And I think that if we eliminated that, it would be much easier to create one tier. But the culture of this country, the racism in this country, the anti-immigrant culture in this country, all of that is going to make it difficult. There's nothing magic about having single payer. It's not going to make all patients want to go to all hospitals. It just won't, because it's the way this country is, but it will help. And it will help, at least the first thing is to acknowledge that the inequity is there, and then do what you can to level the playing. And I think by making all patients equal in terms of being with payer mix, that's a start. I mean, because nobody's worth more than anybody else.
Mm-hmm. I think it would also affect the workforce, right? We see a lot of workforce leaving smaller underpaid clinics and health centers they also need to be paying their quality of life and cost of living and all of that. So mm-hmm. that I think would equalize workforce as well, where these mm-hmm. struggling clinics wouldn't necessarily be losing workforce and be less able to address their patient population. Uh-huh. And also with the wait time, the quality of care, maybe we wouldn't be seeing as many acute instances. It would be more, I think that would kind of lead to more preventative care, just naturally, just equalizing that leveling playing field where people aren't necessarily only going to the hospital now for oh my gosh, I need to go because tomorrow I might die, or this pain is so, I can't even handle this pain. My toothache is now a root canal. I would just go when it was a simple procedure, less expensive procedure, which will mm-hmm. reduce cost overall.
Yeah. I mean, I've seen some horrendous things that patients tolerated for weeks to months mm-hmm. that possibly could have been curable. Mm-hmm. But, by the time they come in, it is more expensive to treat then, but people don't know where they can go. They don't, and even if they go to a hospital, that if they're uninsured, the hospital said, I mean, I can't tell you how many patients were admitted to my service that came with a printed off map quest of how to get to Cook County, because they'll take care of you there, because they were seen somewhere else who wouldn't take care of them. And so here they are, they're sent to a hospital that's far away from where they live, which means they won't get their family to be able to, I mean, the consequences of things like that, people don't even think about,
I wanted to ask one last question before we go into the audience question and answer. I know we're kind of going on. I'm being conscious of time, but I just wanted to ask how reform can address the social determinants of health, right? The impacts of housing, food insecurity, neighborhood safety, financial security that are usually seen outside the healthcare system. How do you think reform would address that for individuals and for communities as a whole?
Well, there's a couple of ways. One, if the community became healthier because they had access to care, people could possibly become more productive. The other thing, when you have a hospital in a neighborhood, that hospital creates jobs. So there's people in that neighborhood who could work at that hospital. And also, when you have people who work in that hospital, they may need a grocery store to stop in close to work before they go home. There's going to be restaurants. There's going to be other stores. It's going to increase business. It is a positive for that community. So it helps address some of that. And then it becomes not an area necessarily that you want to avoid, because there's some positive things that make neighborhoods attractive, that make them inclusive, that make people want to go in that neighborhood, that surround. Whenever you have an area that provides jobs, it's a what's the word? A domino effect in the rest of the community. So it will help. It will help. And the other thing too is that there's a lot of communities that have a lot of mental health issues, a lot of homeless issues, that those could help be addressed and dealt with, so that there's a lot of ways. These are things that take time. It's not like aspirin for a headache. It's not going to be that easy. I don't even know if anybody takes aspirin for a headache anymore, but it's not a quick fix. It's something that will take time, and to build new facilities takes time. So it's not an overnight change, but we have to at least start, and we have to acknowledge what the problem is. And I think now this country doesn't acknowledge the problem. They just keep talking about, well, we have to make care affordable. And again, I ask, affordable for who?
The sooner we have something as basic as healthcare delivered in an equitable way, I think as a society, it sort of compels us a little bit to see how everything about life needs to be delivered in a more equitable way.
Mm-hmm. Yeah.
It can have a domino effect, I believe. I want to go ahead and get to some of the viewer questions. So I'll start with one that has come up repeatedly in the chat, because I think it's something that everybody, you're talking to a group of people who are actively engaged, who like to inspire voters and community participation. And the recurrent question is, while we're waiting for the government to completely address this, what can we do as individuals, and what can we inspire other voters and engaged individuals to start doing now to try and address some of these inequities within our health system?
Yeah, that's getting into the role of activism, because and that involves a lot of things. Calling your congressperson, making visits to the Congress. And you don't need to do this by yourself, 2 or 3 people together, can go talk to Congress. And believe me, a lot of them are receptive, but you have to be sort of vigilant and, keep going. But to be a social activism, get involved in organizations. I know that PNHP has chapters throughout the country in different states. You don't have to be a physician to be a member of PNH. There's a lot of Medicare for all groups. There's Healthcare Now. There's other social activist groups, Public Citizen. There's a lot of groups out there that do this work, the activism work, to address these inequities. One of the things too is to start seeing, if you need to see firsthand what goes on, volunteer at a hospital. I don't know if you can now because of COVID. There's a lot of restrictions on what you can volunteer to do because of COVID, but to see what's happening, volunteer at a school and see, a lot of schools need help with, especially with the younger grades. But develop that sense of social activism, because that's the grassroots where all of this comes from. Like I do my talks to you, but then there's other people who do other things. So we all have our roles that we like. And I say, find something you like doing, because then you'll keep doing it. If you don't like talking on the phone, then calling Congress people maybe isn't what you should say you'll do. But find something that you like doing and grow with that. And I think that'll open other doors. But it's really this grassroots social activism that has to, spread to everyday people, not just politicians, but to everyday people as to why this would work. Organize a talk in your community, in your church, at your school. Do something on single payer, and really get involved and energize yourself so that you can keep motivated. But it really is the grassroots. When there's rallies, go to them.
I think it's also important to note that we don't always have to call our Congress legislators.
And write to
They're
them.
also write to them. They're saying now that social media is a huge driver for legislators. They pay attention to that. There's also a lot of quick actions that you can it's already automated online, and you can just click it and you can see, you can use Google or search engines to just search for the policies on healthcare that are present in your state. And then there's also a website that will do kind of like a layperson's understanding of that bill. And that way you can see if you want to support or not and get a better understanding of that. I've found out a few bills that way, the telehealth bill just that passed in California, to right now there's drug pricing bill that's people are kind of pushing for. And then there's also, I didn't realize how many nuances there are to, like, say, the infrastructure bill. We want to vocalize that we want money and funding for, let's say, community health centers, or for road infrastructure, or depending on what you want to advocate for, there are avenues. And I think we kind of have to be specific, not just, oh, we need an infrastructure bill, but what is kind of learn the nuances of what's being put in the bill itself, I think is kind of important. All of this can be done by just searching online and kind of finding avenues that way. And of course, by searching online and seeing reputable websites and sources, making sure they're mostly, informative and nonpartisan, so you can get all of the informed decision making. So that's just my little 2 cents right there.
And like you said, learn as much about the topic as you can, because that's the way you will be able to convince other people. And, start with family or good friends that, if you say something wrong, they'll forgive you. But that's a good way to start. But the websites that I listed at the end of the talk are very useful to go to get information.
I think there was a question, I read it earlier, but how do we kind of build trust in African American communities? Basically, how is that possible? What steps could be taken? Is that
When you say build trust, trust around what?
healthcare, just addressing, getting people to go seek healthcare when they need it?
That's a difficult issue because of the history of how Blacks have been treated and how they continue to be treated. And there is still so much bias within the healthcare community. And the problem with bias and the structured racism is that it keeps going on and people aren't even aware of it. It's just sort of, it's just sort of considered the norm. But that's a hard one to crack, and it's not. And a lot of people don't trust physicians, not just because of a racial thing or the racial history, but they've had bad experiences.
Mhm.
And, and it's hard you have to be able to show them that you're different if you're a healthcare provider. And that's difficult nowadays because you may never see them again. And why should, I know that as a hospitalist, I found that, and I found it kind of frustrating because that's why I kind of like being a primary care doc, because you got to see the same patients over and over and over, and you do develop a relationship. But even when you're as a hospitalist, when I was taking care of patients in the hospital, you develop a relationship with that. So if you're talking about building trust, it's a time dependent process. It's not quick. It's just like, if you're dating someone, you don't trust them after 2 dates. I mean, it takes time, to get to know them and for people to understand that you're on their side. And especially with healthcare, when you're talking about, you want them to take this medicine or you want them to have this test or whatever, it takes time for people to trust you. And so be patient with it. But, if you can get one person, then that can spread to their family. Oh yeah, go to Dr. A because they're good, or whatever. But acknowledge that it takes time and don't get frustrated because it does take time. But it can be done.
One other thing I would add to that is that it's really important for patients to recognize how valuable continuity of care is in really having a successful outcome working with the clinician. As a former clinician in primary care, I thought that continuity was just critical so often, just to be able to see what did and didn't happen and to appreciate a particular patient and now maybe some new condition that was happening or know what their prior conditions were. It really colors how you go through that diagnostic evaluation of what's going on here or what's in their best interest. And when you have that continuity, it's trusting on both sides, and it lets you move through the process much more effectively, I think. And that, to me, is one of the biggest problems in our current system of your insurer deciding who your doctors are, as opposed to you picking a doctor and then saying, oh, and by the way, this is my insurance. The way it used to be, I think back in the 70s, your doctor would say, oh, and who's your insurance? Okay, well, we'll send the forms to them, as opposed to you now saying, well, insurance company, who can I go see?
And it's interesting because now, when you talk about being able to keep seeing the same provider when you want, I look at concierge medicine, and it just, this whole structure that when you have the money, you can get the structure to work for you, and that's who can do that. So again, we have to change that system that you can't just get that when you have money. It has to be for everybody,
There was one question about just asking to describe a little bit more about the hospital medical industrial I think that was what it was, the hospital medical industrial complex, just to kind of.
It just feeds on each other. They're both for-profit driven industries. If we look at insurance and hospitals and even pharma, that they need each other to function. Insurance, and one of the things that insurance companies are doing is they're taking over areas so that they become a monopoly. You know, because when you look at large hospitals, you know, people want to go to a hospital that's close to where they live, you know, and so they have these networks where most of the doctors in that hospital will be on the insurance plans that people in that neighborhood would join, because that's the hospital that they would want to go to. And so they feed off each other, but they're both driven by getting money, wanting to get money. The insurance company wants your premium dollars. The hospital wants the insurance company to pay their bills. And like I said before, the insurance company doesn't matter what the hospital, doesn't really care what the hospital charges. Because if it doesn't matter if they spend $100 on 10 things or $1,000 on one thing. They just look at the amount of money that they're going to spend, because they have to make sure that that 20% is left for their profit. And so it's all together. They're just motivated by the money, and they're going to make sure that they will deny care. And hospitals don't always like that, because then they have to go after you for the bill and you don't have that money. So it gets to be given, but that's how they work together. It's this sickness, you know, that's just driven by profit. And pharma.
Go ahead. Do you think subsidizing maybe medical schools will drive more physicians towards staying in primary care fields? And
I think subsidizing tuition will do several things. One, it'll increase the number of people who otherwise would not go to medical school, because I think medical students are becoming wealthier and wealthier. And, you know, because they come from wealth, and that wealth can pay their tuition. And they don't have to take loans. Now, they may still choose to go to a high price specialty so that they can stay wealthy, you know, because that's how they grew up. But so one of the problems is that it's making medical students less diverse, you know, because of that tuition. And I think for sure that many students are going into specialties because of their loans and choosing specialties that will pay well enough so that they can do that. And one of the things I try to tell students is that you still have to choose something that you like, that will make you happy, because you'll never make enough money to make you happy. You'll just be an unhappy rich person, you know, but you won't be broke necessarily being an internist. I'm not broke, you know, but, you know, I'm not, you know, I don't have a boat. I don't have, you know, but I'm just saying that, you know, there's still a way to have a very productive, functional life as a primary care physician. But yes, medical school, and it's awful. It's not just medical school, it's undergrad. Because you can't go to medical school without going to undergrad first. And so now you've got 8 years of tuition. And I know when I went to medical school, it cost me more to live. My rent, my food, my transportation costs more than my tuition.
I think I read NYU, you know, they've started offering free
tuition. Yeah. But
the cost of living, even for that, is I think $30,000 a year, and that is sans tuition, like free tuition. So
Yeah.
that's still unlivable for people who aren't working full time, and you can't go to medical school and work even part time.
Right.
It's an impossible feat. So I think being cognizant of that, I mean, a year of medical school is like 80K a year. It's 80,000 a year.
A
So you're
lot of
coming
them,
out
yeah. Yeah, at
of
least.
medical school with like $500,000 worth of debt,
Mhm.
with interest now being accrued. And I think as a resident, you make almost next to nothing. And depending on how long your residency is.
Exactly. And it's, yes, it's a big commitment and it impacts your family. And then, yeah, it's a difficult journey. Even without the finance issue,
Mhm.
it's a difficult journey. And there has to be a way, because you want to attract people who are going into it for the right things, for the right reasons. You want people who, have empathy, who want to do it because they care about. And one of the things I'm really concerned about is the way the healthcare system is going, with all the electronic medical records, and that doctors are looked at as employees. You have 15 minutes to see this patient, and no, I'm sorry your husband died, but we just can't, I can't talk to you about that. I mean, that's not the way it should be.
Mhm.
And
health reform would definitely address this.
well, it would make it so that, yes, you may still be an employee of a group, but that group is not there to make money,
Mhm.
to make such a large profit the way it is now. You're there to provide care. You're there to get to treat your patient. And so you have a little bit more flexibility.
Michelle, did you see the same thing when you at the Students Health Center?
In terms of what people's costs for education were and choices that they made afterward.
And like the reform would just kind of
Yeah,
alleviate the need to kind of churn people out.
it's complicated. I
Okay.
mean, I think it's complicated because we have the system we have now, and I think people don't yet see what it could be.
Mhm.
And so that could still be a driver, but absolutely in the end, when you have what appears to be insurmountable debt, it makes decisions about what kind of career choices you make when you can clearly see the differences in
Yeah.
annual incomes. I wanted to try and capture one other thing that came up in the chat that I wanted to ask you, Dr. Rogers, if your organization or if you personally have seen effective ways of dealing with this, and that is employer costs. It seems there's two different ways of looking at this. First of all, government is an employer, and it is siphoning so much of our tax dollars right now to put it into private health insurance at the municipality level, at the school level, at really just all different agencies within the governments that we pay for. We are paying for their health insurance, and someone made a mention about Congress, if they had the health insurance that we have. So our tax dollars are paying a lot of insurance companies to provide care at tremendous cost that takes those dollars away from the programs we're trying to see thrive. And at the same time, we have a similar thing in the private sector where employers are, as you say, not able to pay people in salary what they have to pay in benefits. But we don't hear very much from employers about the high cost of healthcare enough to sort of mobilize them to maybe take some kind of a pressure or action on trying to change our healthcare financing system. I'm wondering, has PNHP worked with this, or are there organizations that are looking at trying to stimulate either government or private sector employers to get more involved in this issue about health reform, health financing reform?
We don't have a specific aspect of PNHP that addresses that by itself, but we are in with coalitions with labor, and labor, however, works more with the employees versus the employer. But one of the things that employers get is there's a tax advantage they get by paying for health insurance premiums. And this started back in the 40s with World War II. And what they did was that because wages were frozen, they offered health insurance to employees. And that was in lieu of paying them more money. They paid for their health insurance, and the government responded by saying, okay, it's a win-win. And then you can offset, you don't have to pay tax on that money that goes to the insurance company rather than to the salary of that employee. And so that now that, of course, salaries are much greater now than they were in the 40s. So that's a phenomenal amount of tax benefit that large corporations get that they will lose if we have a single payer system. Because what it would be is that employees would then pay what we call a progressive tax. Rather than not getting that salary, they would pay a certain percentage of what their income is, which is actually more fair, because what is happening now is that policy costs $20,000 for your family, whether you make $30,000 a year or $300,000 a year. And so you're paying the same for that insurance. And so the tax would be based on your salary. So your tax would be much less than the person making the $300,000 if you're only making 30. So it would be more appropriate and more, but the employer would lose that tax benefit, and they will fight that. But, they will find a way to avoid it, but they still will not be having to pay that insurance premium.
Exactly.
So they won't, so it won't be a tax on that. So it could be a win-win. I'm not sure how company taxes function, how they do this, I don't know the accounting part of that at all. But you would think that that employers would want that, because then they would have a healthier workforce, and that people wouldn't come to work sick, and that people could continue to do their job, because they feel well. And, it's better that, somebody stay home 2 days with a cold versus get everybody in the office sick, and then everybody has to take 5 days off, so it's to everybody's benefit if the whole workforce is covered and they have access. And it's the same thing if we should have, maternity leave. We're the only industrialized country that does not mandate a maternity leave.
Thank you. Gomel, I'm going to turn it over to you to do our closing.
Yes, and that was a great topic to be ending. And for the sake of time, I really want to thank you both, Dr. Rogers and Michelle, for tonight's presentation, and to our audience. Thank you for taking the time out tonight to really inform and educate our audience and myself and everyone else who will see this recording later. We hope that tonight's program has helped increase understanding of our U.S. healthcare system and has prompted further consideration of opportunities for reform. We hope our league forums can raise nonpartisan awareness of healthcare legislative issues, and we really want to create a better understanding of our current healthcare system and to see what is and what isn't working for all of our communities and how it could be improved and made equitable so it's a level playing field for everyone. Tonight's recording will be available tomorrow morning. It takes a little bit of time to process, and it will be at our league website. It is LWVDavisarea.org. It has been also put down in the chat. Dr. Rogers, would it be okay to share out your slide deck?
Yeah, sure.
Your audience. Awesome. So the slides will also be available on our website. And I just want to thank everyone for joining us this evening. All of our league forums are free for our community and others. And I would love to thank our co-sponsors of over 44 leagues and our featured speaker, Dr. Rogers. Thank you everyone so much. Have a great night.
Thank you.
Thank you for inviting me. I enjoyed this.
Same. Thank you.
Take care. Thank you.